Okay, Shauna, what's the problem here, do you think? Just have to be turned on again, maybe?
Maybe I just had to walk up.
Right, that was it. Okay, good.
Good. Good to know I have a new power.
Yes. Okay, thank you for coming, staying after lunch. And we're talking about Cushing's disease today, Dr. Friedman's innovation with Cushing's disease and new Cushing's medicines. And I think you'll see how Cushing's landscape has changed over these years. Are going to talk about the history of transfemoral surgery, consensus panel on how to work up a patient for Cushing's, medicines affecting cortisol, episodic versus cyclic versus variable Cushing's, why use medicines to treat Cushing's, what medicines can you use to treat Cushing's, side effects and timing of the medicines, use of ketoconazole for a medication trial before surgery, and long-term treatment for Cushing's, and how to determine who should go for surgery. I'll make this full screen. Okay, here we go. Okay. Okay. The transphenoidal approach to pituitary tumors were introduced by Schlofer in 1907. T. Harvey W. Cushing performed his first transphenoidal surgery in 1909 with a patient with acromegaly, using a modified form of the Schlofer method to reach the pituitary gland. However, it was nearly abandoned after Cushing did his first surgery in the late 20s, but then it came back again in the 1960s and is the mainstay for pituitary surgery. The endoscope was introduced for transphenoidal surgery by Gerard Jouet in the early 1960s. In the beginning, the endoscope was used as a microscopic assisted tool to explore the cell cavity for residual tumor. In 1997, the first series of purely endoscopic pituitary surgery was reported by Dr. Joe, who I send a lot of my patients to, and Carew. Since then, many pituitary surgeons have shifted towards endoscopic endonasal approach for pituitary adenomas and paracellular tumors. So you can see here, you take out the, you visualize the tumor and you take it out. So now we have a little bit about surgery. What about, when do you do surgery? Who do you do surgery on? So there was this consensus guideline headed by Maria Flescheroux in 2021, published in Lancet. I think there's somebody missing here, but and we'll go into that. And there was a consensus workshop, 50 academic researchers looking at how to diagnose and screen Cushing's surgery, medical therapy, et cetera. So they have this algorithm here, and I won't go over it all. It's probably really small. Does the patient take exogenous Cushing's? Yes, stop the exogenous. No, look at likelihood. They do 2 tests, either a late night salivary cortisol, 24-hour urine, and they do at least 2 of them, an overnight DEX test. We'll talk about why I don't recommend the DEX test. If these are all negative, Cushing syndrome is all likely. If they're positive, you repeat them again. You can do a test like a DEX-CRH test, which isn't available, the desmopressin test, which isn't good, midnight serum cortisols, which are pretty good. If they're normal, then Cushing's is again unlikely. Consider other conditions if they have psychiatric illness for pseudo-Cushing's. And then you measure if the Cushing's is, they're still abnormal, Cushing's is likely, look at their ACTH level. ACTH dependent Cushing's, you do a pituitary MRI. ACTH independent Cushing's, you do an adrenal CT scan. If you see a tumor, if it's, and this I completely disagree with, if it's greater than 10 millimeters, you send it for surgery. If it's 6 to 9 millimeters, you can do a petrosal sinus sampling. It could still be pituitary Cushing's. Almost all my patients have a tiny pituitary tumor. ACTH leading to cortisol is very potent, so almost never gets to be these large tumors. And then you can look at for ectopic Cushing's or pituitary or adrenal. So this consensus still emphasizes urinary-free cortisol, late-night salivary cortisols, and DEX testing. There's a new emphasis on what I've been advocating for decades: multiple testing, especially the late-night salivary cortisol. Decreased emphasis on DEX-CRH, partially because DEX-CRH isn't available. And I think even the desmotestin test was thought to be pretty successful, but it's not. Almost always it comes back sort of indeterminate. They didn't cite our paper on the low sensitivity and specificity of mild Cushing's, a DEX test in mild Cushing's. They did comment that urinary-free cortisol has a random variation as high as 50%. And there's studies about salivary, same thing. And, they said this is due to the episodic nature of cortisol secretion. Yeah, so that's why you need to measure multiple tests. And that's why if one test is normal, you shouldn't stop there. So I published this article in about 10 years ago. So I looked at overnight DEX tests in 17 patients. And there was 3 of them that had high values, clearly, above 5. Most of them were sort of around this cutoff. I think the assay got a little bit better since then. But, some of these, it's 2, 1. So it's sort of right around the cutoff of that. So many people with true Cushing's do suppress the DEX. So again, if Cushing's is suspected, you can start with the urinary-free cortisol, late-night salivary cortisol DEX suppression test. Could be an option if late night is not feasible. Multiple late-night salivary cortisol might be easier for patients. You can then do urinary-free cortisol. You can average 2 to 3 tests. I don't think that makes sense to average them if one's high and one's low. I don't think you want to average them. A couple of late-night salivary cortisols. Dexamethasone suppression tests might be helpful in people that are shift workers. You should measure DEX levels. Not sure how helpful that is. If it's due to an adrenal tumor, the DEX test is very good. And I think that's becoming the case, that DEX test is good for adrenal Cushing's, but not necessarily for pituitary. Somebody had Cushing's and they recurred, you want to monitor for the recurrence the same way they were diagnosed. So there's no single preferred diagnostic test for Cushing's, nor is there consensus on how to decide whether and when to test, despite attempts to develop a score for ease of diagnosis. Clinical judgment and index of suspicion for Cushing's syndrome are important and underscore the need to individualize decisions about timing and selection of diagnostic testing on the basis of the clinical scenario. Completely agree with that. And need to do multiple testing when the patient is in a high. I think they said that, or I would have said that. So what's missing? First of all, the issue of medicines. I think medicines are crucial for this. Many medicines affect cortisol. Most patients with Cushing's can't sleep. They take a medicine to help them sleep. Those medicines lower their cortisol. So that makes it harder to sleep. Many, some anxiety medicine, depression medicines affect cortisol. It's unclear to be the effect, but it's likely to be somewhat significant. Unclear how long they have to be off these medicines. It's very hard for some people to stop these medicines. I would say at least stop them for a day before testing, but may need longer. Here's a list of some of the medicines. I won't go through all of them, but you can see ketoconazole, mifepristone, somatostatin analogs. You go down to the antidepressants, sertraline, Zoloft. Zoloft actually raises it. Imipramine, trazodone. A lot of people take trazodone. Mirtazapine lowers cortisol. Seroquel lowers it. Restorol, Xanax, Ativan all lowers it. Although the Ativan is probably not that much. On the literature, at least, says no effect. Carbergoline can lower it. Bromocriptine, clonidine, morphine, opiates, buprenorphine. Naltrexone raises it. It's unclear this common medicine given by alternative doctors, low-dose naltrexone. It's unclear about that. Cocaine raises it. Alcohol raises it. Tobacco raises it. Heroin lowers it. Megase can lower it. Growth hormone can lower it. Progesterone could lower it, but I don't think it's that much. Desmopressin can raise it. DHEA can lower it. Diabetes medicine is not used anymore. Avandia lowers it. Pioglitazone can lower it. Serifos supplement can lower it. Ginkgo biloba can lower it. St. John's wort can raise it. Rhodiola can lower it. And I think I put some of these that are substantial in the bold. I think some of these supplements can have a big effect. So this is an unknown area. It's important, I think, to try to figure this out and get people to, if they want to truly test, you have to watch out for these medicines. So then there's this big controversy called episodic, which is what I call it, cyclic, which is what a lot of people call it. And now the new term, and then periodic is what some people call it. And the new term is that some people propose is variable. So periodic and cyclical refer to like sine wave like this. And somebody said you have to have 2 peaks in 1 trough, other people 3 peaks on 2 troughs. To me, this very few people have this, a little cycle. And what's the difference? You know, you want to see whether the cortisol is high or not. Episodic refers to high cortisol levels that are random. Most of my patients are what I call episodic, and I think that would be the best term. There was a review article in Lancet just about 6 months ago or so. Lancet Endocrinology, Diagnostic Challenges in Cyclic Cushing Syndrome, a systematic review. The main person is Martin Renke, who's in Germany. He was at the NIH with me. He's a reasonable guy. He knows me pretty well. They made this comment. I thought, I'm not sure what to make of this. Some studies suggested use of the term mild episodic hypercortisol on the basis of at least one physiological 24-hour urinary free cortisol measurement during repeated testing, and they quoted 2 of my papers. Notably, episodic excessive cortisol secretion and a high degree of variability are characteristics of endogenous hypercortisol and Cushing's. The absence of uniform, so therefore the same thing. You know, if yes, it happens, you should recognize that it happens, and you need to test people multiple times. The absence of a uniform definition for cyclic Cushing's and a common use of alternative terms impede precise reporting of the cases and leave room for interpretation and potentially misinterpret the results. The 2 most widely definitions of cyclical Cushing's are based on 3 hypercortisolemia peaks and cortisol concentration, either by 2 eucortisolemia troughs or 2 peaks separated in 1 trough, of which the latter requires the clinical resolution of clinical symptoms. And then somebody named Sanduk proposed to distinguish between variable hypercortisolemia and non-variable, and true cyclical Cushing's with variable symptoms. So I think this is a little bit of a messy area. And then there was yes, low, below normal, right? So you have, or at least maybe in normal. So you're high and then you're low, or it's lowish. So I was at this Endocrine Society meeting. There was a session called "Here Today, Gone Tomorrow: A Reappraisal of Cyclic Cushing's" by Martin Renke, Symposium 60-02. They tried to define it as peaks and valleys and troughs. They mentioned what I described as episodic can be called variable Cushing's. They thought it was fairly common, so they're sort of catching on with me, but they're still stuck on this term of cyclic Cushing's. They felt that cyclic Cushing's, even though some people say it's super rare, it was about 20% of the cases. And they're going to do a registry of patients, mostly from these doctors in England, to show that it's not more common, which is good. I may or may not send my patients to this registry. I don't know what it takes to send them into the registry. But the key point is most endocrinologists expect to do 1 test. And if that test is negative, they dismiss the patient as not having Cushing's. And I'm sure most of the people who were diagnosed with it got dismissed because they had 1 test normal. So I think you really got to do, probably everybody in the room here. My philosophy is to do multiple testing, dig deeper into whether the patient has Cushing's or not. So we've published a paper called Episodic Cushing's is Common. It was assessing high prevalence and normal tests assessing hypercortisolemia in patients with mild and episodic Cushing's. We found that 65 out of 66 patients had at least 1 normal test. So again, you do 1 test, it's normal. Most endocrinologists would dismiss the patient, but these patients all ended up with Cushing's. And, you know, it depends, the salivary cortisols, the urines, they were fairly similar. None of the tests were that great. You had to do multiple tests. These results about episodic Cushing's that you have to have a high degree of suspicion. No single test was definitive. You couldn't say yes or no 1 test. You have to do multiple testing. So careful history and physical exam in those that are suspected. Multiple tests should be tested on subsequent occasions, especially when they experience signs and symptoms of high cortisol. You know, if they're low, I don't think it just makes sense to test them, but either people don't see it that way or don't understand. So our paper confirmed that most patients with confirmed Cushing's have at least 1 normal value among high values. So therefore, 1 normal test doesn't exclude Cushing's. A series of normal values does make Cushing's unlikely at that time, but a couple years later, somebody could get it. And I think, it really shows that, and I've, done this in my patients since then. People are episodic. They have some normals mixed in with some highs. And, I think it's worse to have episodic because you have lows mixed in with highs. You feel bad both times. You feel a little bit worse in the lows and the highs. You may have less physical symptoms because, it takes years of high cortisol to get the weight gain and buffalo hump and things like that, although most of my patients have it anyways. And then if you're low, some of those symptoms might get better, some of those signs might get better, but the symptoms may not. It can be all types of Cushing's, but almost all my patients are pituitary. So I don't see this that much in the adrenal topic. And I think it's very hard to diagnose and very hard to exclude people not having it. So I agree that you need to see at least 2 different tests. The higher the test, the more likely it is. You're sort of looking like some noise here. You have a cutoff here. If you're up here more, you're going to get more positives than you're down here more. And, you may limit the signs of hypercortisol, less weight gain. You may have the symptoms may just be bad as because of the daytime lows. So you might be just as sick if you have episodic. So I usually do multiple urinary cortisol, 17-hydroxysteroids, a salivary cortisol at night, chest when you're in a high, a midnight serum cortisol. So if you can get a place like in my clinic that's open at night, you have a diary, try to collect when you're in a high. And if you're normal, at least you say they don't have it now. It's always good to re-examine people. Okay, let's talk about medical treatment versus surgery. And I think the key thing is the medical treatment for Cushing's has advanced. There's many drugs to choose from. There used to be very few drugs to choose from, but now there are drugs that have been used widely for Cushing's. And they can be used individually or in combination. And I think I'm quite good, and I'm probably the best in the country at sort of managing the patients with these medical treatments. So I have a lot of nuances on how to treat them. I have one patient who is a lawyer. She lives in Michigan. She's, I think, 32. I think I started treating her when she was maybe 20. She was an undergraduate student. So she's doing, fantastically, at least 12 years, maybe 14 years on the medicines. Many patients are on them for a long period of time. So this idea about, you can only treat them people short term, I don't think it's true. We have surgery, it's invasive brain surgeries, fly out, you have insurance, post-op issues, it's to cure people, it's maybe cures people 70% of the time. You guys were cured the first time, but not always everybody's been cured.
And then sometimes you get, you have the chance of your pituitary not.
Working back, right, exactly. So you got one big, you're
And it's weird. I didn't get ketoconazole, but she did, and she has had a better recovery of
Right.
pituitary.
Yep.
So
It's true.
it's crazy. So it's pituitary.
So this idea about preoperative medical therapy, the more I realize this, I think it's the way to go. I speak at, when we have meetings, I'm not the speaker. I, raise my hand and says, what about this? And the sort of lights go off of the speakers. Yeah, we should really do this, but there's no studies on it, or something like that, And then I think each year it started sinking into the rest of the Cushing's community that I think is the way to go. And I think I see more patients treated by other doctors on medical treatment than there was before. So you can use this to figure out how much the patient's symptoms are due to high cortisol and how much are not. You get the patient healthier before surgery. High cortisol is a surgical risk, have more blood clots, more complications, bleedings, things like that, infections. So you might as well get the patient healthy by making them eucortisolemic. So I give patients ketoconazole usually up to the day before surgery. Ketoconazole, we'll talk about in a second, is my go-to medicine. And then the key thing is there's this idea about cortisol withdrawal. There's a lot of things in the Endocrine Society about that. So when you go from high cortisol down to low, you feel horrible. So if you can lower your cortisol pre-op, you're not going down so far and your recovery is much better. The downside is it's harder to see a drop in cortisol post-op and determine a cure. But in my episodic patients, it's hard to do that anyways. So you have to just sort of give the tincture of time. And I'm working with Rick Rodati that makes Isturisa to try to get a multi-center trial on this. And I'll be interested or not, but we'll see. So what can you use? What kind of medicines can you use? I like ketoconazole the best. I'll explain why. Isturisa, it's called osilodrosat. Works well, but increases cortisol precursor. It's really the same drug as meteropron. Meteropron's been a drug that's been around for a long time. There's Recorlev, which is Levo-ketoconazole. It's the enantiomer of ketoconazole. It's new, it's expensive. Korlym is RU46. It blocks cortisol at the receptor. You can get adrenal insufficiency from it. It's hard to monitor. It's hard to correct the adrenal insufficiency. At least in my end, the owner of the company I'm pretty friendly with. He says he doesn't see that much in his patient in his diet trials, but I do. Cabergoline works a little bit. It's a medicine usually used to lower prolactin or some. There's a medicine called pisureotide. It's a somatostatin analog, Signifor. It works very poorly. It only helps 20 or 30% of the people. Everybody gets diabetes from it. A lot of people get gallbladder issues. I'll talk about that in a second. I would not recommend that to anybody. I'm not sure why it's still in the market. There's a medicine called immunoglutathione. I don't think it's available. Mitotine gives permanent adrenal insufficiency. It's may be helpful. I have one patient on it who's tolerated. It's very hard to tolerate. It's a big pill. It's hard to swallow. Just like gets stuck in your throat. The side effects of the medicine seem similar to adrenal insufficiency. So it's a difficult medicine to use. There's a medicine called Trilostate that can be given IV. We're not going to talk about that today. Sure.
Does topical ketoconazole lower cortisol?
No.
Oh, wow, I wish I would have known that. All the hair growth products have topical ketoconazole.
Right. No.
I've been avoiding them.
Right. No. It's okay. Right. So this is the cortisol synthesis from my chapter in Cecil's Essential. The cortisol pathway is the second column here, second row. You start with cholesterol, pregnenolone, 17-hydroxyprolinol, 17-hydroxyprogesterone, 11-deoxycortisol, and cortisol. That's the glucocorticoid pathway. The top pathway is the mineralocorticoids. Then you have the sex steroids. You have testosterone, estradiol at the end, and then you have enzymes that go down. The enzyme number 5 is 11-beta hydroxylase. That one is the one that's inhibited by hysteresa. The ones in the greenish check box, whatever, hatch box. So that just inhibits one step. So you get a buildup of the enzyme of the cortisol products on that side of it. You also get a buildup of the cortisol going down to testosterone. The ketoconazole blocks these 5 different steps here. So ketoconazole also blocks that enzyme, but also blocks the synthesis from cortisol to pregnenolone, pregnenolone to 17-hydroxypregnenolone. It blocks testosterone. In men, you may not want to block testosterone, but in women, you probably want to block testosterone for a lot of women. So ketoconazole is not FDA approved in the United States for Cushing's. It is approved in Europe, but people can use it all the time. It works by blocking several steps in the cortisol synthesis. It may inhibit pituitary cell growth, so it may have some pituitary effects, although it's not that well studied. It has a short half-life, which I like. So I give it at night, mostly at night, which is when people have high cortisol. Side effect is elevation of liver tests. It's reversible on stopping the drug. It doesn't happen that often. It's more pronounced at higher doses, greater than 1,200 milligrams per day. You should check liver tests at baseline and every 2 to 3 months. It's thought to increase in the EKG, the QT interval, but then there was a study that showed it didn't. So I'm not sure why people are concerned about it if there was a clear study that showed it didn't do it. So Cushing's disease is a disease of high cortisol at night, so I do give it at night. I usually give it like an hour and 3 hours before they go to bed to lower nighttime dose. You can go up on the dose. Sometimes they give it lunch, dinner, and bedtime. You can escalate the dose up to say 1,200 pretty easily. I prescribed 5 milligrams of hydrocortisone in the morning if they get adrenal insufficiency symptoms like nausea, vomiting, diarrhea, abdominal pain, or feeling achy. But it's rare that people need that, but I think it's good to have that on hand. I give patients vitamin E, 400 units a day, and I started in the last year or so giving them milk thistle, which is a supplement that's very good at protecting your liver. So it makes sense to give that too. No downside to giving it. It has an ingredient called silymarin, so I try to give 1,000 milligrams of silymarin to protect the liver. And I really rarely see liver function test abnormalities, probably less than 5% or so, while the literature seems to have much higher rates. I think it was pre-treatment. It helps with the vitamin E in the milk thistle. It does interact with drugs, especially statins, but the statins and other drugs can be given at a lower dose if you're worried about it. So instead of Lipitor 80, you can give Lipitor 40, and then it's like the equivalent of Lipitor 80. You can give a medicine called Crestor, and that would also increase the dose. Now, benzodiazepines are an issue. They're metabolized by the CYP453A4, such as they're not metabolized by this. So lorazepam, oxazepam, and temazepam can be substituted for Xanax, which is metabolized by this. and Ambien. So if you need to give somebody a benzo, you can give them lorazepam, for example. The dose of Eliquis probably should be reduced. There are other interactions, you look on the website and it says Tylenol can interact with it, but I don't really find that the case. I think they're worried that it causes liver tests, and therefore Tylenol can cause liver test abnormalities, so people are concerned about it. Calcium.
So would lorazepam would not be well metabolized with it?
Correct. No, lorazepam is not metabolized by this enzyme, so it's safe to give ketoconazole plus lorazepam. It's not Xanax, but you can probably give like a lower dose of the Xanax. So if you're normally going to take 0.5, you go down to 0.25, and because of the metabolism, it's really the equivalent of 0.5. Calcium may reduce the effect, so it's good to give the calcium separately. If you're going to give calcium, Advair, Flonase, ProAir. Again, you look on the website, there's some listing that, but I don't think it's probably clinically important. There's a concern about drinking alcohol, as that can affect the liver. And grapefruit juice and grapefruit products may increase blood levels of ketoconazole. But again, I use pretty low dose of ketoconazole. So again, if you take a lot of grapefruit, which I don't think people do that much, might raise your 400 level to 600 or 800. So it works in, I think, almost all patients. You look at some of the articles about some of the other medicines, and they work less than ketoconazole. You want to educate the patient about adrenal insufficiency. You can determine how much the patient's symptoms are due to low cortisol and how much are not. Guess the patient be healthy prior to surgery, and I give it again prior to surgery. It decreases the drop in cortisol. I often give it before adrenalectomy. It may decrease this hyperplasia seen on pathology. You want to monitor symptoms. You can measure urine free cortisol. In general, the 17-hydroxysteroids, which are the cortisol metabolites, can go up on this. So I might want to start looking at. Serum cortisol and ACTH are good to look at. Liver function tests. The ACTH should go up. That means it's working. I want to try to look to see if the higher it goes up, the more likely it is Cushing's. Yes, Shauna?
So it says may increase hyperplasia, adrenal.
Right.
Is that because it's decreasing
Cortisol synthesis. Yeah, or synthesis from cortisol. And it can be used for years with monitoring liver function tests and making sure they don't get a pituitary tumor. I think it should be the gold standard and should be compared to it, but because it's a generic cheap drug, probably not going to be. So it lowers testosterone, which is probably good in women, but maybe bad in men. I haven't seen that much of a problem with this either in men. But you theory in a male, which I have much less men than women, you can give testosterone back. So ketoconazole is safe, with the main side effect being increased liver tests, which usually occur at doses greater than 1,000 and are reversible. It interacts with a lot of drugs, but these interactions can be dealt with changing the other drug or watching for side effects. It has a short half-life, so it can be given at night. Cortisol is inappropriately high in Cushing's. Again, it doesn't seem like other endocrinologists get this. And why would you give a medicine in the morning when Cushing's disease is high cortisol at night? I usually give, again, 200 milligrams at 8 and 10 p.m., have them take some hydrocortisone in the morning, if needed. Ketoconazole can be used diagnostically to determine which symptoms the patient has are due to high cortisol. I use it in patients I'm pretty sure has Cushing's, but I'm not completely sure. I want them to feel better. And then they were doing really well on it, so they don't want to stop it. So I'm concerned that if a patient doesn't get better on it, they really don't have Cushing's. I've kept them on, as they said, for 12 years. Usually do another round of testing every year or two or so if I'm still concerned about sending them to surgery, do an MRI, and you want to stop it, I would say, 2 weeks before testing. Now, Levo-ketoconazole is called Recorlev, is made by a company called Xeris. It's an enantiomer, means it's the left hand. Usually you can see the bonds there. They have a left hand and a right hand. So the ketoconazole has both of them. The Levo-ketoconazole just has the left hand one. It is FDA approved. The company claims it's substantially more potent in cortisol synthesis enzymes than the D isomer, but they haven't done any studies on that. It might allow for a lower level of Levo-ketoconazole, might allow a lower dose of Levo-ketoconazole to achieve the same efficacy as the current used doses of racemic or the regular ketoconazole. The dose is 150 milligrams twice a day, which again, it should be given at night. Maximum dose is 1200. And I believe it should be given at night. And the side effects include nauseousness, vomiting, increased blood pressure, low blood pressure, low blood sodium levels, fatigue, headache, abdominal pain, and unusual bleeding. I do see menstrual abnormalities in my patients on ketoconazole, women on ketoconazole. So it reduced the normalized the urine free cortisol in 52% of the patients versus 6% of the placebo. It's good, but I think ketoconazole is better. Most of my patients, about 80% of them get normal cortisols. It's FDA approved. It has a support group called Panther, sort of like that name. Requires a pre-auth. May have less side effects than keto, but I don't think it's been tested. It's expensive, so insurance companies may not cover it. And I haven't really found the need to use it over ketoconazole that I can just call into a pharmacy and they get it the next day kind of thing, versus this that's harder to obtain. I did try it on one patient that didn't tolerate keto, and she didn't tolerate this one either. Isturisa is called oscillodrostat. Works well, has some side effects. It's the same compound as meteropone. It blocks 11-beta hydroxylase, which is the rare type of congenital adrenal hyperplasia. Most congenital adrenal hyperplasia is a 21 hydroxylase deficiency. It builds up the cortisol precursors, unlike ketoconazole, leads to high testosterone, which can lead to extrafacial hair, acne, hair loss, irregular periods. Can lead to low potassium. It can lead to increased cortisol precursors, such as the mineralocorticoids. Like corticosterone is a mineralocorticoid, can give you high blood pressure. So I often add back ketoconazole to the Isturisa to lower these precursors. And so that works pretty well. But if you didn't tolerate the ketoconazole, you had a rash on it, above the LFTs, adding the ketoconazole back is not really an option, or something. It might be at a lower dose. And because it raises your mineralocorticoids, that can lower your potassium, you want to give spironolactone, I think, in most women, because then the spironolactone can interact with the block the mineralocorticoid effects and the testosterone effects. So again, summarizing here, the Isturisa, just this one step here, you get this DOAC, progesterone, 7-hydroxy. Some of these are mineralocorticoids, especially the DOAC. 11-deoxycortisol is probably a mineralocorticoid, and then you get a buildup of testosterone. These can be blocked by the ketoconazole. It's available in the 1, 5, and 10 milligram dose. I usually start with 2 milligrams at bedtime, then I go up to 2 milligrams at 8 and 10 p.m. Maximum dose is usually 15 milligrams. They recommend an EKG yearly, but I don't do that usually. It's expensive. Insurance companies may not approve it, but they have a support group called a Novo, which is pretty helpful. And usually the patients get the medicine with their Novo. It's my second choice. You can again add back ketoconazole to lower the testosterone precursors and testosterone and the precursors. You still get both at night. You still want to watch out for adrenal insufficiency. I find that this is a little stronger, that it really knocks your cortisol off. Cabergoline is a dopamine receptor agonist, a D2 receptor agonist. It can be used at a dose between 0.5 and 7 milligrams. It's usually given twice a week. And side effects include nauseousness, headaches, dizziness. The cardiac valve fibrosis was seen in doses given, was not noted in doses given to patients with Cushing's disease. The treatment was off-label. It's usually approved for prolactinomas. And I had one patient on ketoconazole plus cabergoline. Not sure how we put her on that, but she got put on that. She did really well. She named her daughter Theodora after me. That was a nice story. Okay, so let's go on to Korlym or mifepristone. Mifepristone is a glucocorticoid and progesterone receptor antagonist that can ameliorate signs and symptoms of Cushing's. It's given once a day. It's long acting, so it's different from the ketoconazole. You usually give it 300 or 300 or 1200 milligrams. No advantage of giving it at night because it's long acting.